Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Your host, Dr. George Netto, is the editor-in-chief of Modern Pathology and the chair of pathology at the University of Alabama at Birmingham. Here's Dr. Netto.
Welcome to ModPath Chat. It's my great pleasure today to host Dr. Jinru Shia, Director of GI Pathology at Memorial Sloan Kettering Cancer Center and a Professor of Pathology and Laboratory Medicine at Cornell. Dr. Shia has authored and co-authored more than 300 peer-reviewed papers. Her main research interests include familial colon cancer and Lynch syndrome-associated neoplasm. Jinru will be discussing with us today her group's recent review on what is the best method for detecting mismatch repair deficiency in solid tumors in general. Thank you, Dr. Shia, for accepting my invitation.
Thank you so much, George. I really appreciate this opportunity, and it's on a topic that I'm really passionate about. So thank you.
Yeah. Wonderful. That's what we like. We like excitement, enthusiasm, and teach our audience. So maybe we can start. I think most pathologists know why we use this kind of testing, but it's hard to believe. Till now, there is some progress to make in methodology. So can you share with us why you felt inclined to do this review?
Yeah, certainly, George. As you just mentioned, these tests are super important. We all know that. We've been doing this for more than 20 years, and for the past 20 years, it's serving the one cause that's already very important. That's Lynch detection, which is such a significant cancer syndrome. So that's already very important. And now on top of that, we are adding this aspect of a predicting response to checkpoint inhibitor treatment, and oncologists are all on board. And we know when our oncologists are craving for something that's very powerful. So under that power, we're doing so many of these tests. And I'm really grateful, really very grateful to Modern Pathology to have this opportunity to write this review on this topic. It's
the other way around. We're very appreciative of experts like you choosing our journal.
Yeah, thanks so much. So, going into writing this review, the way I approached it is I thought that there's need to sort of bring to the surface or bring more to the surface some of the tricky scenarios or limitations of these tests. Now, we're obviously talking MMR, IHC, MSI testing, and the different platforms for MSI testing. And these limitations, some, we all know, some are old. Certain issues, they don't seem to go away. Mm-hmm. But some are relatively newly emerged. And we can talk about it again, but this phenomenon of the so-called clonal loss of MMR, IHC is, for example, a newly emerged or newly recognized tricky scenario, and we thought really deserve our attention. And so that's how we approached it, and we wanted to highlight these issues. I mean, the aim wasn't so much to really provide a black and white answer for each of these issues, because for some of these issues, frankly, we don't have a black and white answer. Mm-hmm. So the goal, again, is to simply increase awareness of these tricky scenarios, to know what we don't know and to know when or where we should get worried. And there may be situations, especially with MMR IHC, something we do day in, day out, where the staining may not be normal or abnormal in a black and white way, but there may just be certain unusual findings that suggest that it could still be abnormal, and to be able to recognize those unusual features that should worry us is important. And it's important because we could then utilize other tests, the fallback tests. We could do MSI, we could do germline mutation to catch the real bad actors or the real deficient cases. And so that really is our goal. And to bring all these tricky things to surface.
And I think you've gone a long way in doing that. It's a really an excellent review on the topic, very comprehensive yet easy to read, and really zoom in on these issues that I think all of us dealing with solid tumors need to know that. So I think to make it, to frame the conversation, let's talk first about IHC, which is really what most of the audience, including the ones who are outside the United States, are using for this, and we'll touch a little bit about MSI. But start with IHC. We know the advantage. It's easier, available, cheaper relatively than, although that's changing for molecular getting less and less costly. But tell us, let's focus on the limitations. And I know you're going to spend a little time talking about the clonality issue, small clones issues.
Okay.
So what are the things you first look at to make sure you're not being caught off guard with some limitations of IHC?
Exactly. Yeah. No, thank you, George. And thank you for mentioning about how that you also thought that this was relatively easy to read, the review. And that was indeed our intention. We wanted to make it relatively easy to review. So we were very liberal in utilizing these bullet points. Mm-hmm. And I thank the journal for allowing us to do that. So for IHC, there are many issues with IHC, as we already alluded to, some old issues. But this particular issue that's relatively new that I think is worth talking about is about the definition of MMR IHC. So we all know traditionally the definition for abnormal MMR IHC is loss of staining in the entire tumor, complete loss, right? And so if we phrase it in another way, it would be all absent equals normal. But then people started to realize that MMR abnormal can manifest in the form of partial loss as well. And in our review, we used the term clonal loss for this pattern. Maybe a better term, maybe subclonal loss, but we all know what it means, like a distinct part of the tumor distinctly lost. There's not a lot of literature, but there's some literature on this. And again, in our practice, we certainly have seen these cases and it's gotten our attention. The more you pay attention to something, the more you see it. And one of the cases we encountered was so illustrative, we actually published as a case report. So what happened is that essentially people have come to realize that all etiologies that can cause protein loss, a complete loss of MMR in the tumor, can cause clonal loss as well. So those etiologies, we all know, it can be MLH1 methylation, it can be double somatic mutation or germline mutation. And so that being the case, it is then challenging our conventional definition, which again says that MMR IHC abnormal means complete loss of staining in the entire tumor. And now we are seeing that partial loss or clonal loss may be abnormal as well. And right here, related to this, George, I'd like to emphasize something, number one, and clarify something, number two, related to this issue. And again, I'm really grateful to have this opportunity to talk about this, sure, because these are things I think we need to be very clear about. So the first one, what I wanted to emphasize is the distinction between true clonal loss that we think means something versus those staining variations that pop up rather frequently in MMR stains, but are likely clinically inconsequential. So the point to particularly emphasize is that is that right now at this point, it seems that only when the clonal loss is in a really distinct pattern can we say that the staining could be abnormal. And when we say distinct, we obviously mean distinct. In other words, you really have to have regions of tumor that have loss of staining sharply demarcated from regions that have normal staining. So it's when this type of sharp demarcation happens, can we then say that the case has an abnormal MMR IHC, and we would qualify it that abnormal is in the form of clonal loss. And again, I want to emphasize this because we all know how MMR staining can be so variable and heterogeneous across the tumor, and happens quite often. But the usual pattern we encounter is indistinct. Stained cells, unstained cells, or a weaker stained gland, or a gland not stained, all intimately mixed. Sometimes, oftentimes it is individual cell differences within the same gland or same group of tumor cells.
And that doesn't count.
Right.
And that's what you're saying.
Distinct.
So it needs to be very well demarcated, where you can say this is a clone of cells and they're all losing staining, not expressing. And also, exactly. I imagine the internal control in that area is important because you want to
exactly. That's a great point. We need to emphasize. It can never be overemphasized, the importance of internal control. But I also wanted to point out that some of those indistinct patterns may be abnormal as well. It's just that right now, at the current time, I do not think we are sophisticated enough to pick out which of those indistinct staining heterogeneity is truly abnormal. So at the end of the day, at the current time, only those distinct clonal loss ones can be regarded as abnormal. So that's the thing I wanted to emphasize here. And I think it's kind of important, especially for our trainees out there. And the other one I wanted to clarify is, George, I'm sure you noticed as well, is about how our current CAP recommendations. So our review, this review appeared in May 2022. And in our review, we did mention that the CAP recommendation for MMR IHC abnormal was still complete loss of staining in the entire tumor. And I wanted to clarify that right after, in June 2022, a new guideline was issued by CAP that was published online in June again. This is a guideline for MMR testing, which was framed in the context of immunotherapy checkpoint inhibitor treatment. It was published in the archives, a joint effort with the Association for Molecular Pathology. Yeah. So in this new guideline, there was indeed a mention of clonal loss. Excellent. And so it's really good to see that clonal loss has made it to the guideline. Very nice. Although I guess what I wanted to point out here is that the CAP's good practice statement related to this clonal loss issue is that, I'm going to find this. See, I have this guideline right here. Mm-hmm. And I think I'm going to use the CAP language here. This is what they say. They say, in the event of a clonal loss by IHC, pathologists should perform MSI by PCR, specifically in a dissected area of tumor that has IHC loss of MMR if the patient is being considered for checkpoint inhibitors. And this statement, I know I'm putting myself out there now, I actually take a bit of an issue with. I do not think this particularly necessarily addresses the problem we have, because what this does is simply to test out whether the tumor region that lost MMR on IHC is MSI-high or not. But that we already know. We know it's gonna be MSI, especially if you're dealing with a colon cancer. The concordance between IHC and MSI in colon cancer is nearly perfect. So personally, I think the guidance people are looking for such in such guidelines is what do these cases mean? How do we apply this result? Mm-hmm. And in our review, we have put out some clinical implications that we felt was the case, and we can talk about it.
Yeah, so clearly people need to read the paper. This is very important. So clonal, well, so far we talked about how it needs to be well delimited, well, defined, and with internal controls that are working in that region. But you're saying now that the CAP caught up, not necessarily, you don't think necessarily you have to microdissect that area and show that it's MSI-high, especially in colon. But which brings us to a point that I want to mention that I want to bring up that you're in your paper is a lot of these criteria have been established for colorectal cancer. And as we know, the test is applicable to a lot of other solid tumors. So can you say, at least in the setting of IHC, before we leave the topic, what are the issues that should bring to your example, for example, specifically endometrial cancer and others that are pertinent to these variations?
Yes, I think a principal issue with MMR IHC that we sometimes are not paying that much attention to is the staining intensity is almost directly proportional to the proliferative activity of the cells. Mm-hmm. So I think colorectal tumors are among the tumor types that are a lot more proliferative, and therefore you get good intensity in the internal control, and also in tumors that are so in other words, if MMR is normal in a colon cancer, the staining is very strong. But in other endometrial tumors, it also stains relatively well, comparatively speaking, but not as good as colorectal cancer in my experience. But I think the issues we have with endometrium are tolerable, because we talked about it a lot and people are paying attention to it. Mm-hmm. That what's not tolerable or less easily tolerable are these other tumor types, like a urothelial tumor with the papillary carcinoma, or like a renal tumor, like some other unusual tumor types where the internal control is miserable, and then the tumor staining intensity, even when the MMR protein is normal, is weak, anemic. What do you do then? My only recommendation is do your best, really try to find the normal control and compare with the normal control, and then look around and to see the areas that are best preserved and interpretable, and based on those areas to come to a conclusion. But be liberal to utilize alternative tests. Mm-hmm.
And that's it.
The IHC technique that we have in our lab, I think in all labs really, maybe it is optimized by colon cancer. And so it doesn't necessarily adjust to the proliferative degree, the degree of proliferation in other tumor types. And so we have this issue. We have the same issue with MSI. We can talk about it again. But with IHC, when it applies to these unusual tumor types, that's the issue. And my recommendation, again, is to be liberal in utilizing MSI testing and alternative testing.
Excellent.
If you're dealing with a patient who is young, clinically has family history and so on, high risk population, some people recommend you do both. You not only do MSI, but also do you not only do IHC, but also do MSI.
And that's something that you embedded actually in a red box, and I refer the audience to figure 6 in your paper, talking about your algorithm. So the clinical and the setting is important because even if it's negative, that will guide you whether to do MSI or not.
Exactly.
Either way. So that's a very important point you're bringing. For the limitation of time, can we talk a little bit about anything, what are some important points you want to mention for MSI testing? I mean, beyond the traditional Bethesda, now there are newer techniques. Can you touch a little bit about that and
Sure.
What's the advantage?
Sure. So we obviously are not able to go through all the bullet points we have in the review, but the one particular scenario, which really is in a way a limitation related to MSI testing, is we already touched on this, is how not all MSI is created equal. There's again tumor type differences, much like there's IHC protein, the dosage of the protein difference across tumor types. Here, there's tumor type differences in MSI as well, maybe in the degree of MSI or the specific profiles of MSI or some other aspects. And yet our test platforms, be it PCR-based or NGS-based, are developed and validated primarily according to colon samples. And so they're not calibrated for the various other types, and yet the same test is these same platforms are being used for everything, colon as well as solid tumors, and that is where issues, or one of the main issues or concerns lies. And because of and that concern is that because of the heterogeneity across tumor types, the platforms that are calibrated according to colon cancer may not be ideal for the other tumor types. They may not catch the potentially unique MSI characteristics of those other non-colon tumors. And some actually, maybe many non-colon tumors may have, and they may have an MMR problem, but they may not be MSI-high, like how colon is, in the same way colon is MSI-high. And so because of this issue, this leads us to another area that we emphasized in our review, and that is the existence of these discordant tumors that have MMR protein abnormal by IHC, but you do PCR MSI testing, they're not MSI-high, they're MSS, and this is a issue that has been recognized for quite some time now, and we have seen such cases, and we actually published something a good number of years ago, and others have published as well on this. And the gist of our early publication, as well as the gist for these other publications in the literature, is that certain non-colon, non-canonical Lynch tumors, like mesotheliomas, like adrenocortical tumors, and so on. Again, typically those tumors that are less proliferative, they may lose MMR protein. They have the Lynch syndrome defining MMR protein deficiency, but they're not MSI-high. And more recently, with the NGS data, we further confirmed this finding. And with the NGS data, we also learned something. These tumors, they're not MSI-high, but they're not MSS. We suspected this all along, but NGS proved it, that they fall in between. We have this category of MSI-high, sort of indeterminate. Our MSK Impact MSI census score has this indeterminate category, and these tumors are MSI-high. And our recent study, NGS-based study led by Sophia Stadler, which we quoted in our review, showed that some 30% of non-colon, non-endometrial Lynch-associated tumors do not have MSI. And again, they're not MSS, they are MSI-high. And in our study by IHC, all of the tested MSI-high Lynch-associated tumors showed loss of protein of the protein.
So you can argue the protein is better for these situations.
Yeah. So this again brings to the clinical implication. What do these cases mean, right? So we think, this is our take, like for this MSI tumors, and typically they're not colon, for the purpose of Lynch detection, this is what we think. We think tumors that are found to be MSI by NGS should go on to get tested by IHC, irrespective of tumor type. Again, many of these are may not have had IHC upfront because they're not colon. And so we should go back and do MSI-IHC, do MMR-IHC. And if it is abnormal, then from Lynch detection perspective, they should go on to have germline mutation testing. And in this scenario, I think personally, we can forget about the MSI. It doesn't matter because it's not going to change anything, and it will come back as MSI-high, as our study showed. So go on to do germline testing for Lynch. So that's number one from Lynch perspective. From immunotherapy perspective, I don't think we have a black and white answer again. The implication is still to be defined, but there is some literature. There was a very good study led by Tim Chan from our institution a couple of years back that looked into these things and had showed data, and there's a bit of literature as well, that suggested that the lower degree of MSI in these MSI-high tumors, they're typically accompanied by a lower tumor mutation burden. They may not be sufficient to render the tumor responsive for checkpoint inhibitors. And even though they have MMRD by IHC, and we know currently the regulatory approvals for anti-PD-1 applies to tumors that are either IHC abnormal or MSI-high. And one wonder whether the inclusion of those tumors that are IHC abnormal but not MSI-high might have accounted for the lack of response in some patients. So those are really areas that we highlighted in the review. Yeah.
How exciting! That's there's so many details and
layers.
When to think of it, is it high or S versus is it by immunopositive or negative? It turned out that there's so many shades in between, and most importantly that these have some implication, like you mentioned, with anti-PDL therapy, because maybe that population is low responders and shouldn't be treated with that.
Exactly.
Well, wonderful. This is great. So let's wrap up with some take-home messages.
Sure.
Brief.
Yeah, sure. Thank you, George. So the overarching, the general message is really, again, is to point out that in doing these routine tests, MMR testing, there are a good number of seemingly trivial details, nuances, but they're actually important and that deserve our attention. And I think, if anything, it's just to pay attention to all these details. When it comes to IHC, some nitty-gritty points to take home for our sign-out tomorrow would be, the really important one is the one you mentioned, George, and that is the positive internal control. The importance of it is just so important. When you try to determine whether the tumor cell staining is normal or abnormal, you really have to compare with the internal control, the adjacent non-tumor cells. And this is particularly important when you are dealing with those evolving sort of weak staining in the tumor cells. So if you have a case where the tumor cell staining is, the intensity is consistently weaker than the adjacent stromal non-neoplastic cells, that should get your attention. And that is the time when we should do more work, maybe repeat the IHC or go to the fallback tests, go do MSI, correlate with clinical findings. If there's concern of Lynch, you should do germline mutation. And that really is a key message. And for MSI, same thing. We have to pay attention to all this. We mentioned how the platforms are all calibrated by colon cancers. And so in the bigger picture, to have tumor type specific MSI markers or GM panels may be challenging, but may just be what we will need. But so those are areas and those subsets of tumors that are IHC abnormal but not MSI-high. Their importance in how they respond to checkpoint inhibitors. Those are areas that deserve our attention.
And they're good areas for young investigators to pursue. So
exactly, precisely.
Can't wait to have you back or members of your team on another podcast to discuss more of these exciting techniques. Thank you very much, Dr. Shia, and it's been really a pleasure to have you here.
Thank you very much, George. I appreciate this opportunity. I love talking on these issues. So thank you.
Wonderful.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Springer Nature, UAB, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. Producers are Christina Crow, Amber Jackson, Dr. Sarah Jang, and Dr. Catherine Ketchum. Technical direction is provided by Kaminsky Productions, music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.